Greetings, I'm Dr. Karl Nath, the Editor-in-Chief of Mayo Clinic Proceedings, and I am pleased to welcome you to the multimedia summary for the journal's March 2024 issue. There are 3 articles that have been selected as our editor's choice or highlights articles this month. Our editor's choice this month is a special article entitled Management of Patients with Kidney Disease Undergoing Bariatric Surgery, a Multidisciplinary Approach. It is authored by Dr. Alexandra Kirkler from Mayo Clinic in Rochester, Minnesota, and colleagues from Mayo Clinic in Rochester, Minnesota, and Hradec Králové, Czechia. Eligibility for kidney transplantation requires a pre-specified BMI so as to avoid potential complications that may occur in patients with higher BMIs. For obese patients with stage 4, 5, or 5D chronic kidney disease, CKD, who are potential candidates for a kidney transplant and who exceed this BMI, weight reduction is required. The latter often necessitates bariatric surgery, of which sleeve gastrectomy is the preferred modality. The experience of sleeve gastrectomy is relatively limited in stage 4, 5, or 5D CKD obese patients, and the undertaking of sleeve gastrectomy in this patient population introduces added challenges posed by the presence of such kidney disease. Kirkler and colleagues at Mayo Clinic developed a novel, multidisciplinary collaborative transplant metabolic program called TransMet that integrates evaluation for kidney transplantation and bariatric surgery evaluation for obese patients with chronic kidney disease. Kirkler et al. Discuss these challenges along with important questions in this field that require elucidation. For example, after sleeve gastrectomy in the general population, increased intake of fluid and protein is generally needed, whereas patients with pre-existing stage 4, 5, or 5D CKD are often fluid overloaded, and those not yet on dialysis are protein restricted. Sleeve gastrectomy promotes bone disease and increased skeletal muscle catabolism and sarcopenia, the latter potentially impairing cardiorespiratory fitness and contributing to disability. Stage 4 and 5 chronic kidney disease itself promotes bone disease and sarcopenia. Sleeve gastrectomy commonly enables remission of type 2 diabetes in the general population. However, when performed in patients with stage 4, 5, or 5D CKD, there are such added considerations, including the fact that advanced chronic kidney disease decreases clearance of insulin and renal gluconeogenesis. Indeed, glycemic control may worsen in these patients when renal function is restored by a functioning kidney transplant. Furthermore, conventional indices for assessing glycemic control may not be accurate. Cardiovascular outcomes, including hypertension and psychosocial considerations, represent other salient topics in undertaking sleeve gastrectomy in patients with stage 4, 5, or 5D CKD. In addition to these discussions, Kirkler et al. Delineate 12 areas that are insufficiently understood and are in need of further study. The significance of this article by Kirkler et al. Is at least threefold. First, it provides a current state-of-the-art review of this multidisciplinary topic. Second, it demonstrates how the bringing together of relevant experts and expertise and a team-based approach are essential in managing patients with multi-system medical and surgical issues. And third, it underscores the importance of specifically delineating what we do not know as a way of guiding the direction and the course of future research. Our first highlight this month is an original article entitled Degree of Risk Factor Control and Incident Cardiovascular Diseases in Patients with Hypertension. It is authored by Mr. Minghao Ko and colleagues from Tulane University in New Orleans, Louisiana, and the Harvard T.H. Chan School of Public Health in Boston, Massachusetts. Systemic hypertension now afflicts some 50% of the U.S. population and is one of the most influential risk factors for cardiovascular disease. Indeed, the evidence is persuasive that effectively treating hypertension reduces cardiovascular disease and its mortality, coronary heart disease, and stroke. However, are the benefits of such blood pressure control greater when accompanied by control of other risk factors for cardiovascular disease? To address this question, Ko et al. Utilized the UK Biobank to study cardiovascular outcomes in some 75,000 hypertensive individuals and some 25,000 non-hypertensive controls over a median follow-up of 12 years. The 7 risk factors in this analysis included blood pressure, BMI, low-density lipoprotein cholesterol, hemoglobin A1C, albuminuria, smoking, and physical activity. The data demonstrate that in hypertensive individuals, each additional risk factor control was associated with a 14% to 24% lower risk of cardiovascular disease. For patients with 6 or greater risk factor control, compared with individuals having 2 or less risk factor control, the hazard ratios were 0.49 for cardiovascular disease, 0.51 for coronary heart disease, 0.48 for stroke, and 0.34 for cardiovascular mortality. Indeed, for hypertensive individuals with 6 or greater risk factor control compared with non-hypertensive controls, the excess risk of cardiovascular disease outcomes entirely abated. The beneficial effects associated with a joint risk factor control was much more apparent in male individuals. At least 2 explanations may underlie the beneficial effects associated with joint risk factor control. The first is the tempo at which a given risk factor, when controlled, achieves its beneficial effects. For example, such beneficial effects are achieved within months for control of hypertension, whereas lipid control may take years to exert cardiovascular protection. The second is the mechanism underlying the protective effects associated with control of a given risk factor. For example, notwithstanding overlapping protective processes, the basis for the protective effect of lowering blood pressure may differ in distinct ways compared with those of stopping smoking. Thus, synergistic and summating actions related to the tempo of and mechanisms underlying the protective effects of multiple risk factor control likely underlie the added benefit from joint risk factor control. This important study of Ko et al. Supports a concept that is likely true in the treatment of diseases, namely, strategies that interrupt disease processes at distinct but influential and interacting steps may be more effective than a single strategy alone. Our second highlight this month is a review entitled Advances in Screening for Barrett Esophagus and Esophageal Adenocarcinoma. This topic is expertly addressed by Dr. Kornpung Vantanasiri and colleagues from Mayo Clinic in Rochester, Minnesota. Esophageal adenocarcinoma, a cancer rising in incidence, has a grim prognosis with a 5-year survival rate of some 20%. Its one known predisposing condition is Barrett esophagus, a change characterized by metaplasia of the squamous epithelium of the esophagus. This may progress to dysplasia and esophageal adenocarcinoma. Screening for Barrett esophagus is recommended by national and international societies for individuals with risk factors for Barrett esophagus. These include gastroesophageal reflux disease, a relevant family history, male sex, age older than 50, white race, tobacco use, and a hiatal hernia. The current and conventional approach for such screening is sedated endoscopy, the latter being both costly and invasive. Vantana-Siri et al. Discuss innovations in the use of minimally invasive non-endoscopic tools for detection of Barrett esophagus, in particular swallowable cell sampling devices combined with biomarkers. These devices include a cytosponge and TFF3, a protein biomarker of Barrett esophagus, and other such devices that utilize DNA methylation biomarkers. The authors provide a comprehensive discussion of the challenges and limitations of these techniques, along with their relevant data on their sensitivity and specificity. The authors also review other less developed methodologies, such as esophageal capsule endoscopy, tethered capsule endomicroscopy, exhaled volatile organic compounds, and peripheral blood-sampled molecular biomarkers, including a liquid biopsy using circulating tumor DNA. Advances in risks in assessing Barrett esophagus and esophageal carcinoma are also discussed by the authors, with a focus on two prediction tools validated in independent populations. The authors conclude their review with their hypothetical model, summarizing the emerging paradigm of risk assessment for Barrett esophagus and esophageal adenocarcinoma, early detection of Barrett esophagus by non-endoscopic technologies, and pathways of subsequent management. Vantana-Siri et al. Are to be commended for this superb review that highlights the importance of detecting Barrett esophagus and emerging innovative, minimally invasive, non-endoscopic tools for such screening. You can access these highlights and Editor's Choice articles free of charge during the entire month of March. Please visit our Mayo Clinic Proceedings website at www.mayoclinicproceedings.org, where you'll find our online-only features and many news stories posted in the News from the Editor carousel on our website homepage that are based on articles published in Mayo Clinic Proceedings. You will see other free content as well as articles published online in press. You will also find links to our social media by clicking the buttons at the bottom of the homepage to follow us on Facebook, Twitter, and YouTube. On our YouTube channel, you'll find full-length author interviews called Insights, and our MCP 60 Seconds video article synopses. Our website also includes our Mayo Clinic Proceedings issue summary and Author Insight podcast recordings, which are available from our website on the home page as well as through iTunes. As always, we greatly thank you for your interest in and your support of Mayo Clinic Proceedings. We hope you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.